aneurysms. The incidence of AAAs are estimated to be about 4.5 per 1,000. The risk factors include atherosclerosis, smoking, hypertension, male sex, advancing age, and hyperlipidemia. And there's a high mortality rate if rupture occurs. Why is the use of bedside ultrasound important? Because up to a third of patients with leaking or ruptured AAAs are initially misdiagnosed. Only about 50% of patients with leaking or ruptured AAAs will have the classic triad of back pain, hypotension, and a pulsatile mass. Now, it would be nice if all patients were thin like this. This was a patient who did have a leaking AAA, and you could see and feel the pulsatile mass. However, in most patients that are obese, the physical exam will not be this revealing. The use of bedside ultrasound can rapidly diagnose the presence of a AAA and provide a more rapid patient disposition, decreasing potentially the morbidity rate. Focused aortic ultrasound is highly sensitive for the detection of a AAA. The sensitivity rate is approximately 100%. However, it's poorly sensitive for detecting direct signs of rupture. In terms of transducer selection, in the average adult, you're going to want a transducer that is in the range of 1 to 5 megahertz to allow adequate penetration into the abdominal cavity. You can use a large footprint curvilinear, you can use a small footprint curvilinear, or you can use the phased array transducer. While all of these transducers will work, if I had my choice of one, I would pick the large footprint curvilinear, since this is nice for the displacement of bowel gas. In terms of patient positioning, the exam is usually performed with the patient in the supine position. Since most of the patients you're going to be scanning are obese, you're going to have to use transducer pressure in order to displace bowel gas in order to be able to visualize the abdominal aorta. If you take a look at this patient, when we started off we were able to see nothing because of all the bowel gas. However, with gentle increasing transducer pressure, we're now able to see the aorta. I explained to patients that I'm going to apply gentle transducer pressure in order to better visualize the aorta. You want to make sure that when you're holding the transducer that you're anchored to the patient and you have a comfortable grasp on the transducer. Everyone's aorta has some degree of ectasia. In older patients with atherosclerosis, there's going to be more degree of ectasia, so you're going to have to do a rock and glide technique as you follow the aorta down. It's not going to be like unzipping your jacket in a straight cephalocaudal direction. So you want to make sure that you've got a comfortable hold of the transducer in order to be able to make these fine manipulations of the transducer. Here's a sagittal image of the abdominal aorta, anterior, posterior, head, foot, and here you can see the aorta. It looks here like there's some type of a thrombus within there, but that's because there's such a degree of ectasia that the aorta in this segment here curves off to the side, so you're really not seeing the lumen at that point. That's why it's going to be important to do those rock and glide techniques. Here we have a patient with an atherosclerotic aorta. You can see that as we're scanning down, we're having to move in that and use that rock and glide technique because of the ectasia present. Let's take a look first at the sagittal aortic exam, and the exam is going to be begun with the transducer in the subxiphoid space with the indicator directed towards the patient's head. That's going to provide this type of a view, anterior, posterior, head and foot. As much as possible, you're going to try and use the liver as a sonographic window. Here we can see the proximal aorta, and we can see the first two branches detectable with ultrasound. The first one here is the celiac axis. The next one is going to be the SMA. Note that we don't see the renal vessels because the renal vessels are going to come off at approximately a 4 o'clock and 8 o'clock position, so you're going to end up seeing them on the transverse images. Let's take a look at the mid-aorta. Now as we move the transducer down in this sagittal plane, you can see that we've got still the celiac axis and the SMA. As we start moving now into the mid region, you can see that the aorta is going to become more superficial, so we can change our depth here. You can also see that you're going to lose the sonographic window of the liver, so we're going to have to start dealing with bowel gas. This means that we're going to have to start applying gentle transducer pressure in order to displace the bowel gas so we don't lose visualization of the aorta in this region. Even though you can't directly visualize the takeoff points of the renal arteries on a sagittal image, you can have an idea if you measure about 2 centimeters from the takeoff point of the SMA and go in a caudal direction. In approximately 98% of patients, the takeoff of the renal vessels will be within 10 centimeters of the SMA. And this can be important clinically for the vascular surgeons, since their surgical approach for a suprarenal versus an infrarenal AAA is going to be different. Here's an important point. When you're scanning, make sure that you keep your eyes on the screen at all time. It's very easy with just gentle side-to-side movements to start on the aorta and end up on the inferior vena cava. Here's an example here where we go from the aorta to the inferior vena cava with a very subtle movement from side to side. There you go. Start off here, aorta, gentle slide, and now we're on the inferior vena cava. So you have to be very careful. I've seen cases over the years where people start off on the aorta, end up on the inferior vena cava. And most abdominal aortic aneurysms are going to be infrarenal, and these would be the ones that you would miss if you switched over and started following the inferior vena cava down. So remember, keep your eyes on the screen at all time. So let's go ahead and put the sagittal exam here together. So we're going to start off in the subxiphoid space, and we're going to follow this down to about the level of the umbilicus, which is where the bifurcation occurs. So you can see here we've started off, we're following the aorta. Here we've got the celiac axis, here we have the SMA. If we measured to 2 centimeters from that takeoff point of the SMA, in about 98% of patients, we're going to know that the renals take off within that range. You can see as we follow the aorta down into the mid region here, we no longer have protection of the liver as a sonographic window, so we're going to have to deal with bowel gas. You can also see that the aorta is becoming more superficial. And you can see right at about this point where the vessel appears to be narrowing and then going deeper, this is the bifurcation point. Now you're really not going to see it as well as when you're in the transverse plane because of how the iliacs will take off. But you can see that at this point you're at about the level of the iliacs. You want to try and see as far into the iliacs as possible, since isolated iliac aneurysms can happen and they can present fairly similar to a AAA, but this is the extent of the sagittal exam. It should be relatively quick. Let's take a look now at the transverse exam, and we'll go over some key images at different levels. Transverse exam is going to be started high up in the subxiphoid space, just like you did with the sagittal exam. But with the transverse exam, you're going to have the indicator directed towards the patient's right. So that'll give you this image: anterior, posterior, patient's right, patient's left. Here you've got inferior vena cava. Here you have the aorta, and you've got the vertebral body posterior to that. You always want to make sure that you give yourself enough depth when doing this scan. You can always take or decrease the field of depth somewhat after you've done your initial scan, but it can be problematic starting off too shallow because it can be easy to follow other vessels and assume that that's the aorta and the inferior vena cava. So make sure you give yourself enough depth. But here we are approximately, there's inferior vena cava, and there's aorta, and there's vertebral body. As we slide the transducer down in a caudal direction, we're going to first come across the celiac axis. So again, anterior, posterior, patient's right, patient's left. Here's the inferior vena cava. Here's the aorta. And so you can see the celiac axis coming off. You've got the splenic artery and the hepatic artery here. This is referred to in the ultrasound community as the seagull sign. As we continue to move the transducer down caudally, we're next going to come across the superior mesenteric artery. You can see here, you've got pancreas here. You've got the splenic vein here, which is posterior to the pancreas. Here you can see the superior mesenteric artery. It's anterior to the aorta. Here you've got the vertebral body. Here you've got the inferior vena cava. You have the left renal vein coming across here into the inferior vena cava. The SMA is referred to as a donut sign because of the echogenic tissue surrounding it. It has the appearance of a donut. We move further down. We're going to next come across the renal arteries coming off. So here you've got, you can still see the superior mesenteric artery coming over the top. Here you've got inferior vena cava. Here you have aorta, and you can see the right renal artery here. You could measure the aorta at this level right here and see that there's no evidence of an abdominal aortic aneurysm. So if there was an aneurysm more distal, it would be an infrarenal AAA. Here's an example here. I was scanning with a beginning scanner, and they latched onto these two circular hypoechoic structures right away and called this one the inferior vena cava, this one the aorta. But there's no other landmarks to prove that that's what it was. This was a relatively obese patient, and this is relatively superficial to be the aorta and the inferior vena cava. As we gave ourselves more depth, we were able to see this is the inferior vena cava, this is the aorta, here's vertebral body back here, and so this is the SMV and the SMA. So it's important to make sure you give yourself enough field of depth. You can always take it away if you've given yourself too much depth, but you don't want to be in the situation we were in the original part of the video where we don't have any good reference points for adjacent structures to confirm that this is the inferior vena cava and that this is the aorta. Okay, as we go from the mid to the distal aorta, remember, the aorta is going to become more superficial. You're not going to have the liver as a sonographic window, so you're going to have to use transducer pressure to displace bowel gas. But here you can see inferior vena cava, aorta, and you can see the vertebral body. And you're going to keep following this down until you reach the bifurcation, which you can see right here. And here you've got the right and the left iliac arteries. And that usually occurs at about the level of the umbilicus. And here's just a more detailed look at the bifurcation. You can see the iliacs coming off. Here you've got the distal aorta. Now you've got the right and the left iliac vessels. And this is all at about the level of the umbilicus. Okay, so let's put together the whole transverse exam. You start off high in the subxiphoid space, indicator to the patient's right, and you're just going to follow the vessel all the way down until the bifurcation. And here we have an example here. Here's aorta, inferior vena cava. We're continuing to follow it down. You notice it's becoming more superficial. We're going to have to apply more transducer pressure to get rid of this bowel gas so we don't lose visualization of the aorta. We keep following it down, and there we are at the bifurcation. And this is the transverse aorta exam. So what's the normal aorta going to look like? The normal aorta is going to have a diameter less than 2.5 centimeters, and it should have an anechoic lumen. Here you can see a normal aorta in the sagittal plane and a normal aorta in the transverse plane. You measure the aorta in the transverse plane, make sure that you're perpendicular to the aorta. If you are at an oblique angle, you're going to overestimate the size. So make sure that you're at a perpendicular angle, and you measure from outer wall to outer wall. When you measure in the sagittal plane, you also want to measure from outer wall to outer wall. And it's important when you do the sagittal measurement that you're as close to the mid portion of the vessel as possible, because if you're off to the side here and you're sidewalling the vessel, you're going to underestimate the overall diameter of the vessel. What's a AAA going to look like? It's going to be an abdominal aorta that has a diameter that's greater than 3 centimeters. Here you can see on this sagittal image that the aorta measures 4.69 centimeters. Here you can see at this level transversely that it measures approximately 5 centimeters in the AP and the transverse planes. Secondary findings include the presence of mural thrombus, but this has no bearing on whether or not there's rupture present or not. Both of these were patients who had ruptured AAAs. This AAA has a large amount of mural thrombus within it, and this AAA has essentially no mural thrombus within it. But this was a patient who had a crack in the parietal lumen right here and was hypotensive on arrival. The abdominal aorta is clearly greater than 3 centimeters in diameter, and here you've got this aorta that has a large amount of mural thrombus. But the mainstay of the diagnosis is going to be a diameter greater than 3 centimeters. Most abdominal aortic aneurysms are going to have a fusiform shape, meaning that there's a gentle transition from the normal aorta to the aneurysmal portion of the aorta. And here you can see this is an infrarenal AAA. Here you've got the SMA at about 2 centimeters here. Below that takeoff point, you still do not have evidence of a AAA, but as we scan more caudally, you can see that there's a gentle transition into the aneurysmal part. So this is a patient that has a fusiform aneurysm. Here's a patient that has a saccular aneurysm. You can see on this sagittal view that the aorta goes from a relatively normal diameter to quickly become aneurysmal. These are ones that have a tendency to rupture at a smaller size because there's greater tension on the wall at these transition points. While we did have Doppler on the aorta on this clip here, this was not an essential part of the diagnosis. But you can see that the aneurysm goes from relatively normal dimension to quickly becoming aneurysmal. The next thing we need to look at is, where is the AAA? Is it above the renals, at the level of the renals, or below the level of the renals? Over 90% are going to be infrarenal. This is an important point for the vascular surgeon, since their approaches are going to be different for one that is suprarenal versus infrarenal. So if we can help them out with that information, that's a big plus. What are predictors for rupture of a AAA? Well, once you start getting to a diameter of about 5.5 to 6 centimeters, your risk of rupture dramatically increases. If you've got somebody whose aneurysm is being followed and there's a rapid rate of expansion, that's also another risk for rupture. Some studies have said that the presence of thrombus increases the risk of enlargement and rupture. But when a patient comes in who's symptomatic, you can't use the absence of mural thrombus to say, oh, there's no rupture here. It's a predictor, but in the acute setting, it's not going to play a role in your decision making. And statistically, the risk of rupture is going to be greater in women than in men. The hypotensive patient that came in, here's direct evidence of aortic rupture. You can see here, see how the wall is kind of bowing in on the side there. You can also see that there's a crack in the parietal lumen, and this is a large amount of retroperitoneal hemorrhage here. But you can see here where the wall is kind of bowing in, this is a crack in the parietal lumen here, and blood is rapidly filling into the retroperitoneal space in this patient. So while the sensitivity for direct detection of rupture is poor, it's not impossible, and this is something you want to train yourself to look for. Here's another patient with direct evidence of rupture. You can see there's a crack in the parietal lumen, and you can see the blood pouring out into the retroperitoneal space. So the presence of retroperitoneal hematomas, a crack in the parietal lumen, or the presence of hemoperitoneum are all findings that are suggestive or that will help you in making the diagnosis of an aortic rupture. I believe that when you're looking for retroperitoneal fluid, the best place to look for it is going to be in the flank areas. basically what you do on the trauma exam, looking in the perihepatic and perisplenic windows. Here we've got a patient who has a ruptured AAA. You can see, here's the kidney, here's the liver. Here you can see that there's fluid between the true capsule of the kidney and Gerota's fascia. You can also see that there's evidence of hemoperitoneum. So it's not uncommon for these people to have hemoperitoneum because they get tears in the retroperitoneum and fluid leaks into the peritoneal cavity. The ones who come in with hemoperitoneum usually have small leaks into the peritoneal cavity. If there's a massive tear, these people usually bleed out very quickly and are not resuscitatable. But this was a patient with a ruptured AAA. While we were able to see evidence in the periaortic region of retroperitoneal hematoma, it was much easier to see it up in the areas of the perihepatic and perisplenic windows. Here's an example here of a patient who had an approximately 3.5 centimeter abdominal aortic aneurysm who came in with severe right lower quadrant pain radiating to his back. We were concerned for an abdominal aortic aneurysm, but with an abdominal aorta that measures only 3.5 centimeters, it would seem pretty unlikely that that would be at great risk for rupture. However, as we started scanning further, as we scan further, what you can see is that as we get down into the iliacs, the patient has bilateral iliac artery aneurysms, and his right iliac artery was significantly aneurysmal, and this was the cause of his symptoms. And isolated iliac artery aneurysms can occur in about 15% of patients. So remember, when you get to the bifurcation, follow the iliacs as far as you can in order to look to see if there is the presence of an isolated iliac artery aneurysm. Although not a primary goal of the focused aortic study, sometimes patients, particularly those with type B dissections, are going to come in with back pain, and clinically they may seem very similar to someone with a ruptured AAA. You go ahead and do the scan. You don't find any evidence of aneurysmal dilatation, but you see the presence here on this sagittal image of an intimal flap, and that is what you would use to make the diagnosis of an aortic dissection.